Hi, my name is Ashlee Roffe, and I'm the Nutrition Director at Swedish Hospital. Today's topic is just one in a series of subjects brought to you by Channel 1, On-Demand Nutrition Education. Today, we are looking at assessing energy requirements with indirect calorimetry and elevating the role of the registered dietitian by developing a metabolic monitoring team. So let's just jump right in. What does it mean to elevate the role of the registered dietitian? Well, in 2009, Dr. Stephen McClave wrote an article in NCP, and it was really discussing feeding tubes and how the registered dietitian should be the owner of feeding tubes. That article really resonated with me, but I thought, you know what, maybe it's time to take that one step further, and maybe the registered dietitian should actually be the one that's owning all of nutrition support. So how do we do that? The first step would be to own the literature. We as dietitians are the ones that should be the experts, the go-tos on our medical teams, and we really should be positioning ourselves as the source of evidence-based nutrition to all of the medical teams that we're working with. How do we do that? Well, bring the literature to rounds. Know where your resources are. If you get asked a question and you're not quite sure where it is, find the paper, bring it to your team, and show them that you're the one that's bringing the value of the evidence-based practice to the team. Secondly, we need to own the skills. All of us through our training have had extensive training, but our baseline understanding of physiology, we understand disease states. We are the ones that own the malnutrition diagnosis and the nutrition-focused physical exam. And now the next step to owning nutrition support is to learn to conduct indirect calorimetry testing. In order to do that, we must own the right equipment. Many of us, up until this point, have probably had a pen light as our most expensive piece of equipment in the dietitian toolbox. But now we have the opportunity to really expand that set and to own other equipment that can assist us, and specifically metabolic monitoring equipment. Another way to think about owning nutrition support is to really think about what nutrition support has evolved to be. And I love this quote from a paper by Mary Russell and Dr. Paul Wischmeyer, in which they say that nutrition support in the critically ill has evolved from adjunctive care to provision of a therapeutic strategy designed to, among other benefits, attenuate the stress response and favorably impact immune responses. We as dietitians often get lumped into food service, and people think we are the waitress and we're just there to take preferences, but actually, let's elevate our role and show how we can valuably impact the team. One way that we can do this is by starting to follow something that Dr. Elizabeth Dewale has coined as nutrition stewardship. This is analogous to antibiotic stewardship, which many of us are familiar with. And what we're looking at are the 4 Ds. Are we prescribing the appropriate drug? Meaning, what type of feeding? Is it PN? Is it EN? Is our patient able to eat PL? Are we doing that in the proper dose? Meaning, is our caloric and protein load appropriate? Certainly in this case, a caloric load should be identified by measuring via indirect calorimetry. Are we providing this drug, this feeding, in the proper duration? So when and for how long? And are we really taking time to de-escalate when needed and stopping enteral nutrition or parenteral nutrition when oral intake improves and our patient starts moving into the recovery phase? So as you think about implementing indirect calorimetry in your practice and elevating the role of the dietitian, it's important to remember that the monitor itself, while it's a fun, shiny new tool for the dietitian to have, and you'll certainly get a lot of attention walking down the hall and people wondering why in the heck the dietitian has this monitor and what are you doing with it, that's all great. But if we don't adopt a clinical protocol that helps us interpret the data and utilize the information that the device gives us, then we're really kind of failing ourselves. So how do we do that? Our process at Swedish Hospital is to identify patients and test on a schedule. So every patient on day 3 or 4 of ICU admission gets their first measurement. This is part of the ICALIC recommendations. If you aren't familiar with the indirect calorimetry literature, I would definitely start with that paper from 2017, 18 maybe. We then measure every 2 to 3 days, or if there's a change in clinical condition. We then document, interpret, and share out. And this is really important because if we're utilizing this machine to guide our feeding prescription, we need to share with the medical team why we're doing that and how we're adjusting. We should be checking the tube feeding pumps or looking at the I's and O's to make sure that our patient is receiving the regimen that we have prescribed. And then we continue to establish individualized nutrition therapy. So we want to update that regimen with the same day that we do the test immediately, because we know that's what the patient needs right then and there, and then continue to monitor that intake and measure on that schedule. There are a few clinical considerations of indirect calorimetry measurements in the ICU, and some of this is a little bit challenging in the beginning because we know that nurses are busy, they're doing a lot of different things, and if we're asking them to wait a minute, take into consideration the type of mobilization you're doing and the type of medications you're giving, sometimes that's a challenge. So communication with the interdisciplinary team is certainly a priority. When you look at this list, you can see that most of it is related to things that might affect either the homeostasis of the patient or the just relaxation and calm state of the patient. We're looking to measure resting energy expenditure. So we want to do everything we can to avoid any external factors that would be causing a patient to be unrestful. So things like suctioning, ventilator setting changes, tube feeding, or medication changes, we'd like to avoid those things in the 30 minutes to an hour prior to the test. Another thing is ventilator changes. While we can't always affect that, the medical team may need to change that. We need to be aware, talking to the respiratory therapist, talking to the nurses about what's been going on in the last 30 minutes or an hour prior to your test. So then when should we be measuring? I mentioned this briefly, but I wanted to show you this nice graph from the Oshima paper, the ICALIC paper that I mentioned, measuring somewhere around day 3 or 4 of ICU admission. Remember that in that early phase of acute illness, we have this early endogenous glucose production. So the patient, essentially, you could think about it as they're kind of feeding themselves, right? They have gluconeogenesis going on, glycogenolysis. They have a lot of mobilization of these endogenous substrates. So we want to be really careful about overfeeding. And if we add exogenous energy in those first few days, we could be overfeeding our patient. So really a trophic feed, bathe the gut, get some nutrients in there, protect that gut integrity for the first few days, and then measure around day 3 or 4, and then every 3 or so days afterwards. And then this is a nice practical picture, I think, from a paper by Dr. Van Zanten, looking at that progressive feeding in those early phases. This says day 4, 100%. That may or may not be where we land. Somewhere in day 4, 5, 6, 7 would be where we'd be meeting our first goal, but certainly measuring around day 3 or 4, adjusting our prescription, gradual advancement, and then making sure by about after the first week in the ICU, we are feeding our patient appropriately to the amount that's been measured via indirect calorimetry. A quick couple of case examples. It's actually the same case, but I want to show you the progression of this patient. This is a patient that was admitted to our ICU, status post abdominal surgery, also was dealing with a GI bleed. The patient was intubated and sedated with propofol. And this was day 3 in the ICU, and when we were doing our first IC test. Now, the patient had not been fed. We did not have clearance yet to use the GI tract, so we were not feeding anything. And you can see that this patient was a rather small lady who didn't have, even with predictive equations, did not have a high calorie need. However, when we measured her energy expenditure, we realized she needed just shy of 800 calories per day. With a predictive equation, we would have been feeding her upwards of 1,000 to 1,200 calories per day and potentially overfeeding and negatively impacting her clinical outcomes. So by measuring on day 3, we were able to be more accurate in our TPN prescription that we were starting to provide the next day. Another note here on the indirect calorimetry output is the RQ. So you can see the RQ on here is 0.67, and many of us dietitians were trained that the RQ tells us what kind of substrate the patient is using. I want to just remind us all that RQ is a good indicator of whether we have a valid test or not. It should be within physiologic range. And in this case, since the patient was on propofol and was not getting any other feeding, it tracked and made sense. It was part of my clinical assessment toolbox to say, okay, yeah, that low RQ does make sense to me, but we should not be using that as an absolute value of the substrates that are being utilized. This is the same patient. This is ICU day 10, so now a week later from that first test. The patient now was on TPN, and the REE, you can see, was increased by almost 500 calories. So the patient at this point was moving into a more recovery stage, was able to be extubated shortly thereafter, and we were able to still really impact her nutrition by providing her a feeding regimen as she transitioned to enteral nutrition off of TPN to meet her measured energy needs, which we would not have known had we not measured by indirect calorimetry. Thanks so much for joining my presentation today. I would invite you to watch for upcoming Channel 1 nutrition videos and learn more from my esteemed colleagues. Have a great day. Thanks for watching.